Let's turn off our cameras. So, welcome, ladies and gentlemen, friends and colleagues. On behalf of the Standards of Practice Committee, as chair, I would like to welcome you to this debut of our new series promoting the best practice. This is the best practice series, which will give us a library in due course of different things relating to endoscopy, different disciplines. And we elected to start our series with small bowel capsule endoscopy. This is part one of a series that will dedicate itself to the small bowel. So the part two will revisit device-assisted enteroscopy. And it is a huge pleasure for me to welcome you all, and also to welcome all our key guests. These are world experts in the field of capsule endoscopy. And together with my co-chair, Tibor Gyokeres, who is the vice chair of the Standards of Practice Committee of the WEO, we shall be helping guide you through this webinar with the start of our key experts, starting off with Professor Drey from Paris, Martin Keuchel from Germany, and also Cristiano Spada from Rome, Italy. So I'd like to introduce Tibor, my co-chair, to bring in the next speaker. But just before that, I would like to do some housekeeping. So note that the raise your hand and chat function have been disabled. And if you have any questions for us, please use the Q&A box for the questions. Okay, so Tibor, if you could introduce Xavier, I'd be very grateful. Thank you.
Okay, thank you very much. Just before it, I should mention that in recent years, Edward, our chair, has been appointed officer in the National Order of Merit in Malta, his mother country. Congratulations.
Yep.
Okay, now let's move to the first speaker, who is Javier Drey. He is a professor of medicine at Sorbonne University and Saint Antoine Hospital, Paris, France. He's an authority on capsule endoscopy and artificial intelligence, and also a founding member of iCare Group. Javier?
Thank you.
Thank you, and well, thank you first for the invitation to this webinar, and again, congratulations, Edward. My topic is patient selection and preparation to small bowel capsule endoscopy. I do have some conflicts of interest. Let me first go through this slide where you can see the patient's pathway. As for any procedure, an endoscopic procedure, of course, before doing small bowel capsule.
Xavier, can I kindly ask you to share your screen, please, because we're not seeing your slides.
Oh, I'm very sorry. I thought I did. Okay. Any chance you can see my screen now?
We can see the test, yeah.
Yes, we see it now. Thank you.
Yeah, sure. I'm very sorry about this. So yes, the very first step of capsule endoscopy is, of course, to weight indications, contraindication, and to get your patient informed and consent. And then he will go through his pathway to the examination, swallowing the capsule, possibly be prepped for the examination. And depending on the device you use, he may be equipped, in most cases, he will be equipped with a sensor belt and a data recorder before you read and interpret the capsule. That will be detailed by Martin and Cristiano in the next talks. So let's go first through patient selection. Again, you should wait first indications. The first major indication, which encompasses for about 2/3 of all small bowel capsule endoscopy, is suspected small bowel bleeding. That is a gastrointestinal bleeding where an upper GI endoscopy and a colonoscopy did not find a source of bleeding. If the bleeding is occult, it relates to iron deficiency anemia. If it is an overt bleeding, we know that the diagnostic yield of small bowel capsule endoscopy will be significantly higher if you perform capsule endoscopy within 48 hours after the bleeding episode, which means that you have to be pretty quick to do the upper GI endoscopy and the colonoscopy. I believe it is most relevant if, of course, the bleeding is ongoing. The second major indication is suspected Crohn's disease. Still, ileocolonoscopy is the first endoscopic examination in these patients. But in case where you have a negative ileocolonoscopy, and I would say as well, if it is available, a negative fecal calprotectin, then you should go for small bowel endoscopy, capsule endoscopy. And in this case, you don't need any cross-sectional small bowel imaging or patency capsule prior to the real capsule endoscopy. There are other high-yield indications like definitive Crohn's disease, where you may be interested in documenting a jejunal involvement of these patients and possibly monitoring small bowel mucosal healing if you do this capsule in a treat-to-target strategy. For any patients ongoing capsule endoscopy, small bowel capsule endoscopy, you should stop NSAID drugs, including low-dose aspirin, when it is possible, before you perform the exam, because it may be confusing to find small ulcers in the small bowel. You would not be able to differentiate whether it comes from NSAID or from Crohn's disease. There are other high-yield indications, such as refractory celiac disease, some polyposis, like Pöttger's disease, Lynch disease, and in cases where cross-sectional imaging has found a mass or tumor in patients in the small bowel, you may consider device-assisted enteroscopy if available for sampling or resection, but you may also consider on a case-by-case basis to perform a small bowel capsule endoscopy. So the next step is, of course, if you feel your patient is in the list of those indications, you must, of course, wait and seek for contraindications. There are several lists, I would say, of contraindication. The first three, in my opinion, are not real contraindications. Regarding cardiac devices, it is often noticed by manufacturers that they are contraindications. Pacemakers, left ventricular assist devices, and implantable cardioverter defibrillators. Actually, they may interfere with the capsule, but it is very unlikely that the capsule interferes with those stimulators. So you may lose some small bowel images, but you will not break down the pacemaker or other electric devices. In patients with pregnancy, ascites, and obesity, you may lose images as well because the sensors are actually away from the capsule. In those cases, you should place the belt in the back of your patient. And then you have those patients with surgically altered gastric anatomy without stenosis, where you may consider that the capsule may stay in retention in the stomach or esophagus of these patients. We have actually shown that in those patients who do not have stenosis, it is not a contraindication, and those patients have a similar completion rate, meaning that the capsule does reach the cecum in most patients, in 84% of patients, that the retention rate is low, and that the diagnostic yield is similar to what's seen in patients without any upper GI modified anatomy. And then you have relative contraindications. Those patients with swallowing disorder, in those patients, you should fear capsule aspiration. In very young patients, younger than 8-year-old, in those patients with Zenker diverticulum, and in patients with upper GI stenosis, you may consider the endoscopic gastrointestinal placement of the capsule with dedicated devices or with endoscopic nets. In patients with motility disorders, if patients have a documented gastroparesia, you should consider a pharmacological treatment that may be the combination of a one-day liquid diet and prokinetics. And in other patients, you should as well consider endoscopic gastrointestinal placement. And then we move to strong contraindications. Those patients listed here are at risk for capsule retention. Let me remind you that the definition of capsule retention is no capsule excretion within 14 days from capsule ingestion. These patients are mainly patients with definitive Crohn's disease, 4 to 5% retention rate, patients with obstructive symptoms, 10 to 20% retention rate, patients with small bowel tumors, 10 to 25% retention rate, and patients with a past history of small bowel surgery or a history of long-term NSAID intake. We don't know the percentage here, but we know for sure that they are at risk. In those patients at risk, it is recommended to perform a patency capsule. It is a capsule with an envelope of cellulose, but the content is made of lactose and barium. They should swallow those patency capsule in the morning and get a plain abdominal X-ray in the next afternoon. If the capsule is still visible on the plain abdominal X-ray, it means that the patient is at risk for capsule for retention of the real capsule, which is of exactly the same size. It means that in those patients, there is a formal contraindication for the real capsule endoscopy to be performed. And then the absolute contraindication, in my opinion, is a past history of abdominal or pelvic radiation therapy. First, in those patients, they are often referred because they have iron deficiency anemia, but they may have iron deficiency anemia because they have a radiation enteropathy. So you may not need to do any further investigation. Then, if you would perform a capsule or a patency capsule, you may face retention. And if you ever face retention, it would be really challenging to retrieve those capsules into a small bowel where stenosis are quite frequent and narrow. And furthermore, surgery would be a high risk of fistula in these patients. So you would rather consider cross-sectional imaging, device-assisted endoscopy if absolutely indicated, but you should not go, I believe, in capsule endoscopy and even in patency capsule in those patients. So let's move now to patients preparation. How do we prepare those patients? For the first question is, how do we obtain a bowel emptying, a bowel cleansing? We have to keep in mind that any prolonged capsule staying in the upper GI tract may delay or preclude the capsule to reach the cecum. And that would mean an incomplete small bowel examination. In addition, residues, fluids, bile, and bubbles decrease the visualization of the gastrointestinal mucosa. And then, of course, there is no suction or lavage capability in capsule endoscopy. A very first step for patients prep is to avoid unnecessary medicine. Those patients are often referred for iron deficiency anemia, and of course, you should stop any oral iron replacement therapy. And then, if patients can escape it, they should not take drugs before they ingest their capsule, but after. And I believe in the 2 hours following capsule ingestion. And then, of course, patients should come with an empty stomach, so they should be fasting overnight. We know that in this case, capsule endoscopy completion is around 85 to 90%. And we may consider prokinetics for selected patients with delayed gastric emptying, that is, patients with non-gastroparesis, patients who previously failed examination because they had a prolonged esophageal staying, and possibly in patients where you clinically suspect gastroparesis, although you did not strictly document it. That is, mainly patients with long-standing unstable diabetes. You should strongly consider to give anti-foaming agent to these patients. It is a really cheap and very safe drug, and it is shown in this systemic review and meta-analysis that it does significantly decrease the amount of bubbles that precludes the visualization of the small bowel mucosa. And then the main question is, should you give any purge to these patients? There are many studies on this matter, but I believe they are now outdated and somehow contradictory. But we now have 2 recent large multicentric randomized controlled trials which do not show any impact of the purge on the diagnostic yield of these patients. So let me go through one of these studies, and of course I picked the French one. The PREPENTEST study, more than 800 patients with suspected small bowel bleeding, they have been randomized into 3 groups. PrEP 1, they just received the standard diet, fasting overnight. PrEP 2, they received 500 millimeters of PEG 30 minutes following capsule ingestion. And group 3, they received 2 liters of PEG on the evening before, and then 500 millimeters, again, 30 minutes following capsule ingestion. And look, the diagnostic yield in all 3 groups was around 40%, similar in the 3 groups. And the completion rate, again, this is the proportion of capsule which reach the cecum, was around 90% in all groups. So you may decide not to give any purge to these patients. But if you check those lines, the cleanliness score, although this score is not absolutely reproducible, you can see here that your comfort in reading the capsule, the visualization of the mucosa seems significantly higher in those patients who received some amount of PEG. There was no difference between group 2 and group 3. So in my opinion, giving 500 millimeters of PEG 30 minutes following capsule ingestion should be enough in a majority of patients. So in conclusions, ladies and gentlemen, I will give you some tips about my own practice in my setting. The main indication for capsule endoscopy is suspected small bowel bleeding, and when it is indicated in overt suspected small bowel bleeding, we do perform capsule within 48 hours. The second main indication is suspected Crohn's disease, and I believe it should be done when available after negative fecal calprotectin. And there are some other indications such as Gyokeres disease, where we do capsule endoscopy every 2 years, Lynch syndrome, where we alternate capsule endoscopy and MRI every 2 years, and other indications are really rarities, including, in my practice, Crohn's disease follow-up. We do perform patency capsule only for at-risk patients for retention, and we never do capsule endoscopy in any patients who had a history of abdominal or pelvic radiation therapy. We do have a form to inform our patients, and they are expected to consent, of course. And then we ask our patient to stop any drug, including NSAID. They start a low residue liquid diet on the day before, they fast overnight, and then they come in the morning for capsule endoscopy. They are welcomed by our nurse, and we did build a specific checklist to make absolutely sure there is no contraindication, at least no strong contraindication. And then they swallow the capsule, they get 500 millimeters of PEG with citrate and simeticon. The use of erythromycin is for selected patients only with gastroparesia, and it is now exceptional that we do deliver capsule with a scope. Then we ask our patients to move, so the capsule can reach more easily the cecum. Patients are allowed to drink 2 hours following capsule ingestion and to eat solid food 4 hours after capsule ingestion. I thank you very much for your attention.
Thank you so much, Javier. That was a really, really interesting and succinct overview of what we need to understand when we come to decide on who needs a capsule and how to prepare them. Thank you. So the next speaker is Professor Martin Keuchel from Hamburg. He leads the endoscopy department at the Bethesda Krankenhaus, and he is a world authority on capsule endoscopy and is the editor of the seminal atlas and textbook on capsule endoscopy, which is now in its 3rd edition. So Martin, could you kindly talk us through how to report the footage and how to interpret the capsule findings, please? Thank you so much.
Thank you very much, Ed and Tibor. Thanks, Ed, for the kind introduction, and congrats as well from my side. So I hope you can see the screen. My talk is about the interpretation and reporting of the small bowel capsule endoscopy footage. So it's important to have findings, of course, and it's important to localize these findings to show where we are. And it's quite difficult to do so because the small bowel is long, tortuous, and it's very mobile. So there are trials to localize something about dividing the small bowel into jejunum, which is in the right upper quadrant localized here and comprises about 2/5 of the entire small bowel, and the ileum, which is located more on the right lower side of the abdomen and comprises about 3/5 of the small bowel. And you can see how mobile this thing is. And there is already from 1955 an interesting study by Dr. Underhill, which came to my attention by Paul Swain, the pioneer of capsule endoscopy, stating that the length of the small bowel is 22 feet, as every medical student knows. But what few people realize is that the variation of the length is 100%. So it's very untrustable, the length, and not really predictable. So what else do we have? We have morphological changes like the folds, the density and height of the folds, which is a little bit different from the jejunum to the ileum. The villi are a little bit different, and the vessels are different. But there are no really changes here. sorry, my presentation, it's running on its own. But we have no border in between the jejunum and the ileum, and it's only different at the extreme ends. We do have some landmarks, and these landmarks are gastric heterotopia in the duodenal bulb, prunus glands. We can see the duodenal bulb and the pylorus. We can see the papilla with bile. And on the other side, we can see lymph follicles in the terminal ileum and the ileocecal valve with the passage to the colon. So it's all about the time and the length of the small bowel, which is divided into parts. And for that, we need to define the first duodenal image and the first cecal image. This is the same thing for every type of capsule and for every software. So we define these time points, and then we have a mean small bowel transit time of about 4 hours. But here again, it's very variable. Like the length, also the transit time is very different. We have here an example with a small bowel footage of less than 6 minutes. And this is a duodenal diverticulum. You can see bile here. It's not a surgical altered small bowel with a transit for the small bowel only of less than 3 minutes. And in contrast, we also have a length of small bowel of about 10 hours, and even then it may be incomplete, even in the absence of retention or stricture. This is a very important thing we have to report about the footage, if the small bowel transit is complete, if you can visualize the entire small bowel or not, because all the calculations depend on the totally visualized small bowel. We can divide the jejunum and ileum to proximal and distal parts, which is provided by the minimal standard terminology. And we have another approach by a capsule endoscopy standard terminology, which is set up on the minimal standard terminology. And it's a little bit more simplified by dividing the small bowel, apart from any anatomical differences, to the proximal, the mid, and the distal tertile. So in the beginning, these were just equal times, considering a regular linear transit, but this has been also modified by software calculating the velocity of the capsule. This classification of small bowel tertiles is quite helpful in diffuse diseases like villus atrophy, diverticular ulcers, erosion, polyps. Here we have, as Xavier told, about radiation changes, capsule pierced after patency capsule in this case. And we can further divide each tertile, each third of the small bowel, into a short segment, only about 10% of the entire tertile, a long segment up to 50%, or a whole segment, which is more than 50% of each tertile. Here an example of diffuse lesions in a patient with multiple angiectasias, and they were distributed all over the small bowel, the entire small bowel. That means all 3 tertiles, and we can differentiate its proximal predominance of these angiectasias, which is quite typical. And furthermore, we can describe other findings like fresh blood in the proximal small bowel, and this was only a short segment of the proximal tertile, and we see hematine in the entire distal small bowel. So we can describe what we see throughout the small bowel. Sometimes it's very helpful to have a graphic visualization of the footage, like here in softwares, which is not available in all softwares and not available in any software, in some softwares anymore. But you can see it's quite nice here to see the orange parts showing the duodenal seas and the ligament of Treitz, and you can nicely localize a lesion here to the proximal small bowel, in addition to the time codes. Furthermore, we have softwares providing a percentage of the small bowel traveled by the capsule at this actual point where the lesion is seen. But this is not a real graphical solution. It's just putting the percentage on a predefined graphic here. However, percentage is quite helpful when trying to reach single lesions. And there have been studies how this percentage of capsule travel can predict which route for insertion of device-assisted endoscopy is best. The studies have been done by double balloon endoscopy. The first study also included gastric transit, but this is an additional variable which should be omitted. So further studies just look at the beginning of the small bowel to the end of the small bowel. And we see here in all these studies, proximal to 50%, we should use the oral insertion route. And some studies find that even if lesions are located a little bit more distally, it is helpful to use the oral route. In this last study, there's also some variation of the transit time by computer calculated movements. So this is correcting just a little bit the linear transit. And probably it's quite realistic here to look at these studies because from the proximal approach, it's quite easy. And for the very distal part, it's also easy to choose the insertion route. And in the middle, it's a little bit challenging sometimes. And not all lesions are within reach of an endoscope. And it's not only about the proximal, the oral or retrograde anal route for insertion, but sometimes if we have a very proximal lesion like here, very short part of the duodenum, we can use a gastroscope to reach that. While it is more further down in the proximal jejunum, we might need a push endoscope. And for lesions like that, it's mandatory to use a device-assisted endoscope as well. And lesions like these, like 70% transit time in the right lower quadrant, it is helpful to use the retrograde approach via the terminal ileum. This division of the small bowel into parts is sometimes a little bit altered and has some bias we see here, the capsule in the duodenal bulb for 1 hour. So if you look at these images, we can see the capsule stays in the duodenal bulb for more than 1 hour. And we have to consider this when looking for the insertion route. And sometimes it may be helpful in these cases just to change where the first duodenal image is set for the software to have the correct calculation. And we have lesions that hold up the capsule. And many times for Meckel's diverticulum, as seen here, I think it's probably a minor criterion for the diagnosis that the capsule is held up in this region. If it drops into the diverticulum or not, there is some regional transit abnormality in these cases. And of course, in strictures, the capsule is often held up for some time, which modifies the localization as well. So it's not only about delayed transit, but the capsule may pop back to the duodenal bulb. We see here a pylorus, which is quite wide due to gastric metaplasia going back to the duodenal bulb. And after more than 1 hour, the capsule comes back to the pylorus. So if you see things like that by a landmark, we have to calculate that as well. And of course, all that postoperative anatomy after gastric resection, biliary resection, we cannot use the regular division of the small bowel. It's rather better to describe the localization in between the anastomosis. And of course, we have to be aware that a complete capsule endoscopy in terms of quality parameters can only be from the proximal anastomosis to the cecum, or the distal anastomosis may be ileocecal anastomosis, but we can never complete the small bowel by looking to the afferent loop with the capsule endoscopy. And I just mentioned to have the transit to the artificial intelligence. We have sometimes capsules held up, like here in a duodenal diverticulum. It looks a little bit scarry, mucosa-like in the colon. We have to recognize that. And also the software does recognize that. If you look here at the tertiles, the first tertile is marked brightly. It's very, very long because the capsule stays there for hours. And this is calculated by the software. And once the capsule passes through the rest of the small bowel, we see only a very short tertile here. and a normal-sized tertile, the distal one, until the anastomosis after ileal resection for Crohn's disease with some small ulcers here at the anastomosis. So our report, in conclusion, should contain completeness of the small bowel visualization, the entire small bowel transit time, location of single lesions best as a percentage of small bowel transit time, together with a recommendation for the insertion route for endoscopy if necessary. We can describe the extent of diffuse lesions by tertiles or part of the tertiles. And of course, we should mention transit abnormalities and any surgical alterations. Thank you very much.
Thank you very much, Martin.
Yes. Thank you, Tibor. Please introduce the next speaker.
Okay, our last speaker from Rome, Italy is Cristiano Spada, professor of medicine and gastroenterology at Catholic University and head of endoscopy at the Gemelli Hospital. He's an authority on capsule endoscopy, its expanding role, and artificial intelligence.
So thank you very much for this kind invitation, and it's a pleasure for me today to share with you our experience, and I mean our, because it's not me, but most of the participants on this webinar have been involved in the trials that have been performed to test and to prove that the system is good enough to, and the artificial intelligence can improve our outcomes in capsule endoscopy. So if you remember, when we talk about capsule endoscopy in general, and usually we define the capsule endoscopy as a non-invasive and patient-friendly endoscopic tool. And this is true, is absolutely non-invasive for our patient. But what about the physicians? What about the doctors who needs to explore and to spend time for a capsule video evaluation? So the question is also doctor friendly, and in fact, what we know is that when we are in front of a capsule video, we spend a lot of time. And so in principle, the artificial intelligence in capsule endoscopy can be a prime candidate for early adoption of artificial intelligence. And this is mainly because it's not a real-time procedure, so we can play with the video as long as we want. And it's a very long recording. It's between 8 to 10 hours. And when we sit in front of capsule endoscopy video, we mainly look at normal images, and we can have only few frames, fleeting frames with abnormalities. And so we have a risk, and the risk is to miss this finding. And a part of the risk of missing finding, in general, the capsule reading is very time consuming. And this is a need that is not new to reduce the reading time. If we look at the different technologies during the years, actually there was a huge interest from companies to reduce the reading time, and they developed different algorithms in order to reduce the reading time. But in fact, none of these technology actually enter in the real time, in the real life. And in fact, also the guidelines, they don't support to use these algorithms to replace the standard video reading. A big change happened in the recent year when artificial intelligence, and in particular the CNN and convolutional neural networks, entered the medicine, and in particular in this topic, the endoscopy. And if we look at the impact of artificial intelligence in capsule endoscopy, is not very much different from what we know from colonoscopy. So we are mainly looking at detection, and we are starting looking at characterization. But then we have some specific topic for capsule endoscopy that, in my opinion, should be considered a priority. That means the capsule localization. We know how imprecise we are when we define the lesion location in the small bowel. And also the prep evaluation, we are still using a different scale that mainly none are really validated. And then we might use also the artificial intelligence for quality parameters evaluation with the final goal to improve our quality. Well, if we look at the literature, actually, we already have some meta-analysis and systematic review. And if you look at the accuracy in terms of sensitivity and specificity for the most frequent findings that we look at capsule endoscopy, that means inflammatory lesions like erosions and ulceration, GI bleeding, and neoplastic lesions, we have excellent sensitivity and specificity. So we might say, okay, artificial intelligence is good enough to replace the standard reading. But then if we go in details and look at the different trials that populated this meta-analysis, you will realize that most of them are retrospective studies, and most of them actually they didn't cover, they were not of these papers, of these studies, actually they didn't use a complete video, but they use only small clips and or even still images. So what I mean is that it's true that we have a sensitivity and specificity that are excellent, but actually we are not very much convinced that these numbers can be translated directly in the real life setting. So we were involved in different trials. This was an initial trials where we went to analyze basic artificial intelligence software. And if you look at the per patient and the per lesion analysis was excellent with almost 100% accuracy, both in per patient and per lesion analysis. And then when we went to analyze the reading time, you see that the reading time went to 70 minutes down to 13 minutes with a significant reduction of the number of images that were included in the videos when the artificial intelligence was used. But even a more advanced system, that is a deep convolutional neural networks algorithm, was during the last few years developed with a very clear goal: high sensitivity and high efficiency. So high accuracy and reduction, an important reduction in terms of reading time. And if you look at the data source that was used to train this system, this is something that is incredible. Almost 7,000 videos with 113 millions of images that were used to train and to validate the system. And actually, the impact in our reading time is incredible, because actually, as I was mentioning before, this is how we are looking today, the video. We are sitting in front of a video, mainly looking at normal images. And then this is how it works with artificial intelligence. So you see that the system, you see this blue bar is jumping from one side to another side, just delaying what is in the middle and what is normal. Well, we have a binary division with this artificial intelligence. There is normal versus abnormal. The abnormal doesn't mean pathology. So it's only between, the differentiation is between normal and abnormal. And we already have some preliminary data showing that we can increase our accuracy if we use the artificial intelligence. And this at the beginning was a surprise for me, because I said, well, how a system can be better off an expert? But actually, if we think at the very beginning of this talk about the recording time and how long is the video, and it can happen that we can be distracted for a call or a colleague that enters the room, but the artificial intelligence system never gets distracted, is always working 100%, and this is why we improve our detection rate, and we significantly reduce the reading time that goes in this paper from 90 minutes down to 6 minutes. Well, this trial was performed using a retrospective trial, and so we went to analyze, to design a trial in which we enrolled prospectively bleeding patients. And we included in the Arctic trial 133 patients, and you see that the completion rate reached the standard defined by the European Society of Gastrointestinal Endoscopy in terms of completion rate and cleansing level. Well, again, if we look at the per-patient analysis, we were able to demonstrate that if we use artificial intelligence system, reading assisted by artificial intelligence, we can improve our performance in terms of sensitivity, negative predictive value, and in general, the diagnostic accuracy. And as a surrogate of our performance, we can use also the miss rate. And if we compare the miss rate using the standard reading and the artificial intelligence reading compared to a panel of experts, you see that when we use the artificial intelligence reading, we miss less than in standard reading. And what about the diagnostic yield? Well, you see that if we compare the standard reading and the ProScan, that means the artificial intelligence reading and the board reading, actually there is a difference between standard reading and the board reading, and between the standard reading and the artificial intelligence reading, there is almost 20% of improvement. What is strange is, at least at the beginning, is that there is not improvement between the artificial intelligence and the board reading. So at the beginning, this might be considered like an unsatisfactory result. But if we think deeper in this difference, this means that actually the artificial intelligence is at least comparable to a board reading that is composed by 2, 4, 6, and myself, 7 persons. So the artificial intelligence actually is working as 7 experts working together. So, and in my opinion, this is a huge improvement. Then if we look also the per lesion analysis, again, when we use the artificial intelligence, we have a better accuracy, and the artificial intelligence is not inferior and even superior to the standard reading. And again, in the per lesion analysis, again, we miss less when we read the capsule endoscopy video using the artificial intelligence. This is not the only surprise, in my opinion, but the big surprise is about the reading time. Well, we went from a mean reading time for the small bowel of 33 minutes down to less than 4 minutes. And this means that we reduce the reading time by 10 times. And also the mean image that actually populate videos is reduced by 20 times when we simply switch on our artificial intelligence algorithm. So this is not the only experience that we start having from different companies. Also, we have this other system that has been published on JAMA Network Open. And again, we have exactly the same result. If we use the artificial intelligence, we improve our detection rate and we reduce dramatically the reading time. So in conclusion, the system, as was mentioned Ed before, actually this artificial intelligence system will change very much our performance, because the data that we have up to now seems to show that we can improve our efficacy because we improve our detection and we reduce very much our reading time. And this is really a very big surprise, because we can improve also probably the outcome in our patient. So up to now, we mentioned only about detection, but we are companies are still working on characterization, and this is a paper coming from last year published on endoscopy, just confirming that it's not only about again detection, but we are still we are already start talking also about characterization. But look, also coming, the information that is coming from this paper is about the impact that can have the artificial intelligence on trainees. You see that the trainees without artificial intelligence have an 86% overall accuracy that goes up to 98, exactly the same as expert when we switch on the artificial intelligence. So we have really a new perspectives that artificial intelligence will open. Again, is not only about detection, characterization, training, but also the prep quality evaluation, the relevance of the definition of clinical relevance, size measurement, and also quality parameters implementation. And also it should be interesting to know what will be the impact of artificial intelligence in the outcome of our patients. So we have different topics, and this is why the artificial intelligence, the ESG, try to make some priorities, and the priorities should be the cleansing level, the priorities should be the completeness of procedures, so the identification of landmark, and of course the reduction of reading time and improvement of capsule of diagnostic yield. We have problem of bioethics, and so we should be very cautious when we adopt these systems, because we can have a problem of bias. I just give you an example. On the left, if I train my system to recognize this one as an angiodysplasia, a vascular malformation, then my system will be able to detect this one as an angiodysplasia. But however, if I train my system to recognize this red spot that is not significant as an angiodysplasia, then I will have a lot of false positives. So it's very important the quality of training in this system, in this artificial intelligence system. So in conclusion, the data that we have again confirm that capsule endoscopy could be a prime candidate for early adoption of artificial intelligence. The systems that we have up to now seems to be able to differentiate abnormal images from normal images and to reduce very much the reading time. We need trials to understand the impact of these systems in the clinical outcome of our patients. Most of them are, most of the trials have been performed using as an indication gastrointestinal, suspected small bowel bleeding. We need to prove that this system are good enough also for other indication, and also the cost effectiveness of artificial intelligence need to be further explored. Thank you very much for your invitation.
Thank you so much, Cristiano, for that brilliant overview of what's happening now, especially driven by artificial intelligence. Really. Tibor, I'm not sure we have any questions from the audience yet, but I would like to start off by asking Cristiano and the whole panel really a question. Do you think, guys, that given these tremendously impressive results that Cristiano showed, down from 33 minutes to less than 4 minutes with a sublime accuracy, do you think we are ready to adopt this in mainstream clinical practice from now?
I start.
All of you, you start, please.
I can start, and I think that well, actually, I think that we have only few studies about this, and our trial that where you and Martin and Xavier were a part, I hope that will be published soon, but we still have only few papers on real life situation, and having used this one in trials, but also in my regular activities, I am quite confident in using this artificial intelligence system, because seems also in real life, in routine life, seems to be good enough in terms of diagnostic accuracy and reduction of reading time. Well, at the very beginning, we were very much focusing on reading time, and we didn't realize that the systems are able also to improve our performances. So I'm quite confident that in the near future, we will use artificial intelligence as prime reader for our capsule.
Martin, Xavier, your thoughts on this same comment?
Yeah, I think we are very close to AI doing that job, but there are some things we have to consider. It's not everything that ESGE commented is implemented. This is completeness, landmarks, cleanliness, and these things. And I think for red lesions, polyps, AI may be even better and help us to improve our detection rate. We still have to consider things like transit abnormalities, diverticular, interoception, and things like that. We have to see that AI can also show that. But of course, if we have for a very short run and do have a lot of relevant findings already, it will very much improve and fasten our diagnosis. In the meantime, I think at least in cases where we have normal findings, we should have a personal look still at these videos.
Yes, Xavier.
Yeah, I feel pretty much the same. AI is actually in its infancy. It's like 3 or 4 years old. It's growing, it's learning. So at the moment, I believe we only have one prospective study, the one conducted by Cristiano, and we are very proud we've been able to participate, to contribute. But it is only one prospective study in one specific setting, suspected small bowel bleeding. What about Crohn's disease? What about other indications? So it's too early, in my opinion, to fully adopt it. I currently use it as a backup. I read my capsule, and in the meantime, AI reads my capsule as well, and then I compare. I have to admit it's working extremely well in all indications, actually, but it's not a randomized controlled trial. It's just my opinion. Okay, well, then in the future, I would say in a few years, actually, I believe it will definitely detect, characterize, probably not locate, score your cleanliness, and hopefully write the report. I mean, once you know where is the lesion, what it is, it will definitely write the report. Then the clinical decision will still remain on us, I believe.
Yes, very wise, and I think I concur with that. Tibor, are there any other questions from the audience, or do you have a question for the panel?
No, from audience. I also want to underline the future, because the future of artificial intelligence in the capsule endoscopy, because in a Western world, we have a shortage of doctors, shortage of gastroenterologists, and we have all of shortage of time. So artificial intelligence will save our not only souls, but save our time. And it's very important, that becomes more and more important. If I can ask something, it's a little bit different, but I would like to take an opportunity to ask all panelists and even my co-chair, what do you think about the future of therapeutic capsule? I mean, a capsule that will be able to get histology. What do you think? Is it the future, near future, or never? What do you think? Start, Edward, please.
Difficult question, this, because it's been studied a lot, and it's a bit like space exploration. Who knows? I think with artificial intelligence, if you can combine it with some physiological assessment and the ability to stop the capsule in that region and deliver drugs specifically in that region or sample, it may be potentially possible. I think we're still a way off, though. I think the future of capsule in the here and now is still a diagnostic one, especially fueled by artificial intelligence. But I will gather the thoughts of our colleagues here. Cristiano, what do you think?
Well, this is something that is we are talking about this since a lot of years now, but actually it's never entered. And then I think that we have the big problems. Because if you think at the therapeutic, you have to solve the problem how to control the movement of the capsule to get the target. And we have a magnet, but magnet is not good enough to control the movement of the capsule in the small bowel. It's quite efficient for the stomach, but not for the small bowel. And well, personally, I think that the future will be a combination between endoscopy and liquid biopsy, and we don't need endoscopy anymore to make biopsy.
Martin and Xavier.
Well, there are a lot of efforts to do all these things in single studies, almost on the bench, but it's difficult to combine everything, as Cristiano said. Want to control the steering, actuation, and then to targetedly deliver therapy, and all these things in a very small capsule. So everything works on its own in an experimental setting, but to get it into humans, everything working together will take a long time. And I think we'll stay for diagnostic capsule and therapeutic endoscopy for, I think, at least the next 10 years.
Mm-hmm.
I believe we retired before we see that. And but look, in the years 1970, only Isaac Asimov was able to predict that we would travel in the body of our patients with miniaturized devices, and it's a routine practice with capsule endoscopy. So yes, I believe that will happen. Capsules delivering drugs, capsule arresting the microbiome. Well, but it's in the far future, in my opinion.
Yes, I have another question for you, Xavier. So you brilliantly talked about the risks of retention and what we do, etc., etc. As you probably know, not probably, as you all know, rather, the main manufacturing company, or the one that commands the greatest market share probably in the world, has recently removed the radio frequency identification tag, their RFID tag, from the patency capsules. To those in the audience who do not know, an RFID is a tiny rod which used to send signals to a wand-like device. Imagine a mobile phone. It's a wand-like device, and when these two interact, you hear a sound and you flash a light. And that gives us an early indication that the patency capsule is still within the body. Now, with that removed, we are more reliant on specifics. You mentioned X-ray. X-ray can have a bit of a dicey role because no radiologist, even if they're the most expert in the world, can tell with 100% certainty whether it's in the small bowel or in the colon. So how do you circumvent this obstacle race that has been created? Because it has created some issues.
Yeah. Unfortunately, we just have to accept that it's not here anymore. So in the most trickiest cases, we do actually perform a CT scan without IV injection to see if the barium content of the patency capsule is whether in the small bowel or in the colon. And that's where we stand today.
And just for our listeners, for our participants, can you kindly go over a short protocol for the patency? Because, you know, the patency capsule has two plugs that allow ingress of water, and that's how it starts to dissolve and not cause obstruction. When are we duty bound to examine it every time? Because sometimes the patency passes because of partial disruption, and that can create a dilemma, because if you then give the real capsule, it still can get stuck.
Yes, it's not a 100% reassurance test. It's 97. In the most difficult cases, you still can combine this test with MRI to check for stenosis, dilations, but you still may face retentions, although you did perform both examinations. And yes, you're right. You should definitely ask your patient if he faced any pain during the journey of the patency capsule. That does happen, and in this case, you should not deliver the true capsule. And yes, you may examine the patency capsule if the patients ever retrieve it, which is not that easy. Truly, in my routine practice, I just rely on plain abdominal X-ray, except in, I would say, extreme cases where I do CT scan. Again, no injection, so it's pretty fast for radiologists. I must confess, I do not recall patients for pain and retrieve patencies. I should. So you're right to mention it. I should.
Okay. Thank you so much for that. Cristiano and Martin, the final question before we conclude, because it is a Friday evening and I'll get shot otherwise. So localization. Martin talked about it beautifully. He talked about the recent studies and how intelligent systems are getting to grips with the speed of travel, because let's face it, we are all dependent on transit through a long organ here to localize. And many a time, if we get it wrong, we get a patient for an anterograde double balloon enteroscopy, dive very deep and not find the lesion, tattoo, and have to get the patient back. So do you think the future, both of you, do you think the future is bright for localization? Can artificial intelligence help us here? Do you know of any new things that may be on the horizon?
Yeah, I will start. I think that yes, probably the artificial intelligence will help us, and we actually we try to locate, and I use the terminology try because we are not precise at all, using the time. And you add that you are an excellent deep enteroscopist. You know how imprecise we are when we try a capsule endoscopy to localize our lesion. And we use time. I think that artificial intelligence can do not only the evaluation by time, but also by content, by the morphology of villi, by the size measurement of the lumen. So at the same time, it can include different evaluations and give us an idea, at least if it's proximal, medium, or distal part of the small bowel. This is my personal opinion. But we don't have any data. We know that companies probably are working on this, but I never had the opportunity to test and it will be even difficult to test because what's our comparator? Is deep enteroscopy? What? So, but I think the artificial intelligence somehow will help.
Yes, Martin, on that point, and then we have a question from the audience, Tibor, and then we'll wrap up. So, Martin,
yeah, I
that point,
totally agree with Cristiano. We have some good tools, some hints, but it's very imprecise, and I really hope for artificial intelligence to improve and to do some fine-tuning to help us more get directly to the location. Yeah?
Yeah, difficult one. Tibor, would you like to present the question from the audience?
Yes, we have a question from Barcelona, as I see. Does the use of artificial intelligence make telematic work easier or more difficult? Or is it indifferent? I mean the evaluation of the capsules in the home environment.
Xavier, why don't you shoot that?
Yeah, I can definitely answer that. Some companies are working on it. The future, at least in part, for outpatients is to deliver capsule at home. Probably with some green drivers or something. We actually have submitted a paper that shows that the main carbon footprint from capsule endoscopy is the patient going to the clinics, to the hospital. So we should definitely deliver at home. Plus, many patients do have internet network from home, and some data recorder may send data to the network just like your iPhone does, or your smartphone, I mean. So that will definitely happen. That will not impact all of our patients. So it will be mainly, obviously, for outpatients, but truly, this is the future. Yes. Great question.
Amazing.
I agree
so
with
guys,
actually, we are thinking at workstation as solid physical workstations. Actually, we can have the software and the artificial intelligence on a cloud. So the capsule, the video goes directly to the cloud, and then you can connect from the train, airplane, wherever you are, and play with that.
Super. So really, thank you all. I'd like to thank my co-chair Tibor for kindly hosting this WEO webinar with me. The panel of tremendous authority with Xavier Drey, Martin Keuchel, and Cristiano Spada. Thank you so much. It seems like the future is really bright. At least in the world of capsule endoscopy, and artificial intelligence will certainly make our lives easier and possibly also help us to improve patient care. This was the first part of the best practice series that will become a library available online for posterity, where our WEO members and others around the world will be able to tap into this broad wealth of knowledge. The next one will be in February, where we will concentrate on device-assisted enteroscopy or balloon-assisted enteroscopy, followed by several others pertaining both to the upper GI tract and the lower GI tract throughout the year. We have great experts coming to our next one, including Professor Pennacchio from Torino, Hironori Yamamoto from Jichi Medical University in Japan, and we'll have a good interactive discussion, especially given recent events in this field. And also, I wish to invite you on behalf of the World Endoscopy Organization to attend ENDO 2024. As you know, this is the cornerstone of the World Endoscopy Organization. It's a great conference, and this time it's going to be held in July in Seoul, Korea. And finally, I'd like to thank the WEO sponsors, without whom we won't be able to survive as a great organization. The World Endoscopy Organization stands to promote excellence throughout the world, wherever we are, wherever the region, even in the absence of societies such as the American Society or the European Society. Remember that there are many parts of the world that don't have a representative organization producing guidelines and guiding the way with best practice. And this is where the WEO comes in, the voice of world endoscopy. Thank you so much, and see you next time, and have a great weekend.
Thank you. Bye.
Bye-bye.
Thank you. Bye.
Thank you. Bye.
Thank you, guys. Thank you. It was really great. Thank you. Have a great